It gives me great pleasure to welcome our audience at the National Press Club here in Washington, D.C., and a terrific panel. We've moved up our agenda. Congressman Rohrabacher had to return to Congress, and it's great to know that he's back hard at work to serve us here. We're going to move to our advanced leadership panel and have a group discussion from some terrific leaders from multiple sectors in our, on our national scene, and really address some of the principles of advanced leadership. This group has recently seen, in the last couple of hours, a documentary that'll be premiered tonight at the National Press Club and then be shown at the, on the Discovery Channel. What I'd like to do before we get started, though, is to go through a few housekeeping details for our audiences that are logging in. And typically, TMIT has a WebEx system, so those of you that are on the WebEx system today, you'll be able to hear audio. There will not be a large slide deck because we're streaming video from our website. And if you go to Safety Leaders, www.safetyleaders.org, you'll have the opportunity of being able to log on for the streaming video. You must have a fast line, so those that are logging on now, and if you aren't able to watch the streaming video, we just want to remind everyone that the videotape will be entirely edited with the panels. They'll be available in the next 10 business days because we have an entire day of panels that we're covering. They'll be edited together. Transcripts, word searchable transcripts will be also on safetyleaders.org, and it'll likely take 2 to 3 weeks, but continuing medical education, continuing education units will be available as well, although there will be a little bit more of a delay. For those of you that are on the WebEx, we'd like to remind you that if your audio is not working well, to make sure the audio in your computer is turned up as high as it can be. And if that doesn't work, then go on to our website and or go in the lower left-hand corner of your screen, and you'll be able to identify how to ask for a phone line that would then allow you to have better audio. Those that are streaming, we will, if you have interruptions in service, you could go back to the WebEx, and if you miss that, you can watch this asynchronously. We've moved up our schedule because Congressman Rohrabacher, who gave us, I think, a wonderful inspirational introduction to the focus of what we're doing here today, and Nancy Conrad, wife of Pete Conrad, who died the preventable death of a systems failure, although he lived his life in a high-risk environment, is a very dedicated patient safety champion, and also shared her sentiments and thoughts with us. And we also have given our 2012 Patient Safety Pete Conrad Award to some wonderful recipients who are also with me on the panel today. So we'll start off with our Advanced Leadership Initiative discussion and the concepts of advanced leadership and how we really can apply that to the challenges of quality and safety that we are focused on today. And it's a wonderful honor to be working almost every week with Dr. Steve Swenson, who has been the leader of quality at the Cleveland at the Mayo Clinic, and has been and you work at the Cleveland Clinic too, and yeah, along with Dr. Henderson. No, Dr. Swenson has been the chairman of radiology. A wonderful contributor to that field. He has been a wonderful champion to patient safety, working with us over the years, and now is taking the helm of leadership development for the Mayo Clinic, but we're not going to let go of you yet, Steve. And he is also one of our 2012 Pete Conrad Award winners. Steve, why don't you kick us off with, we've had discussions with all our panelists on what their primary messages are around these topics. Steve, just go ahead and we'll keep my talking short. And what is important about this area?
If the leadership of an organization starts with the patient first, they'll always make the right decision. And then quality, safety, and outcomes and superlative care becomes the central part of the business strategy and not an expense. And so through the patient's eyes, they don't want variation, waste, or defect in their care. And if you deliver that methodically, then it also aligns with the business strategy of the institution.
And at the Mayo Clinic, you've shown a terrific ROI. You've been able to show that focusing on doing the right thing has a financial impact, and that leadership is a good investment.
So exactly, doing the right thing for the patients, driving out waste, variation, defect, also has important financial dividends. And so with systems engineering, with a methodical look at the whole practice to standardize to excellence, we've shown a 5-to-1 return on investment analyzed by our financial colleagues for doing the right thing and for the best care for every patient every day, Chuck.
Fantastic. Dr. David Parda, another radiation oncologist. I kind of feel whenever we talk about radiation safety, which we did in the movie a little earlier, I think that we both have a little heart flutter because this is an area that we've been trained in. And Dr. David Parda is the chairman of radiation oncology at West Penn Allegheny Healthcare System. More importantly, I think, he's a trustee. So he is a clinically trained trustee who is practicing at the same system where he now is a trustee in the full measure of the word. Also a champion for cultural transformation, has an MBA, so understands the business part and runs a very substantial business that is as big as many businesses out there within that system. David, your thoughts from where you sit, where you stand depends on where you sit, and you sit on the board.
It's very difficult for board members, just like doctors, to keep their complete focus on patients. The patients have all of the answers for us, yet we get busy with many activities outside of that direct patient focus. At the board level, most of that is related to assessing financial performance in multiple corporate and hospital entities. And that really does hurt the focus on care, the continuum of care, and it really doesn't allow for us to integrate clinical, operational, and financial activities. That's been my take-home message for 3 years on our health system board, and with more of a focus on the patient, everything else falls in place.
So do you think that doctors can make good board members, and do they need to be trained in being able to be good board members?
I must say that it took me a little while to learn how to treat board meetings less like a morbidity and mortality conference and more like a little bit more of a civilized discussion than what we have in the clinical and operational environment. But we have 4 physicians out of 20 board members there, and that clinical and operational context is critical. That educational component to help educate the other board members on the clinical and operational environments is critical, and I've certainly been very well educated by the other board members on how to organize things at a macro level better. Fantastic.
John Nance is so accomplished that I would take 30 minutes to read his bio. An airline pilot, a lawyer, a best-selling author, but more importantly, a fabulous champion and leader and teacher of leaders at hospitals. Really impassioned. His books, I give them to everyone. Sometimes I give more than one of the same book to them. Have you read John's book? Yeah, Chuck, you sent me 2 of them. And I have to keep track because I have a stack of them. And everyone that we mentor, we send John's books because they're fabulous. And John, you have last night we talked about the transfer of aviation and the principles of aviation with Sully Sullenberger and members of Congress and that kind of thing. You're in a place where you're in the boards constantly and you see the potential crossover. Is there a place for us to really develop leadership, take it to a whole new level, and maybe learn from other industries?
This is one of the hidden critical elements, I think, is leadership. My definition of leadership is you define your worth as a leader by how well you can extract, orchestrate, and apply all the human talent available to you. That means it transcends all the elements that we have boards considering all the time, just as you were saying, David, the finances get in the way. There are a lot of things that get in the way of understanding that we have to change to a patient-centric system. You could say centered, you can say a lot of things, that's just my take on it. But the basic idea is that everything has to be subordinate to the best interest of the patient. The news in this, if you will, and I guess it's probably hackneyed, but it is the 100th anniversary of the sinking of the Titanic, and the old saw about moving deck chairs around on the Titanic is still very appropriate. We tend to still do that to try to readjust things. This is a major cultural revolution if we are going to focus on what we need to do for the patient. That takes leadership at all levels. Leadership in the boardroom, leadership in the C-suite, and leadership down on the front lines where they really do have the answers, but they don't even know they have. So what we're talking about is a total revolution. That responds, or I should say, requires the leadership and the involvement of everybody, and it requires also understanding that you can't make this a priority. Safety, quality have to be core values. If they're not core values, we're never going to get where we need to go.
So we've just started with checklists. There's more that we can learn from aviation, nuclear power, and other areas.
You know, I tend to get on my soapbox so much I even forget about aviation, but we've got, when you're in this kind of a revolutionary situation, you need to look outside the borders of even the most complex thing we've got in life, which is, I think, medical practice in so many different areas. But you look outside and you say, first, last, and always, it's a human system. What other human systems have achieved high reliability status? And if we can identify them, what have they done to do that? Well, we have aviation. That's probably the clearest one in terms of all the things that we've learned, because we learn in very embarrassing fashions when we make mistakes. Nuclear power generation, nuclear submarines, the nuclear navy, on and on. Manufacturing. Atul Gawande did a brilliant job in his book, The Checklist Manifesto, of pointing out that those who build large buildings also engage in exactly the same type of rigorous planning and discipline and minimization of variables and best practices, which we have not seen, not imposed, but incorporated into medical practice.
Sharon, you are such a wonderful, just breath of fresh air to us to have a trustee that's outside of our field of healthcare and to be dedicating yourself to be a great trustee. Sharon was entered through the American Hospital Association Minority Trustee Development Program. And when I talked to Malik Joshi, another one of my wonderful committee members working with the National Quality Forum, said, you know, we've got a terrific set of people. And he said, I bet we've got a really great one for you. And Sharon was in the movie. Really inspirational, dedicated, and I think she proves that you don't have to be a clinical person to really wade in. She's the chair of patient safety at Sinai Health System in Chicago. And John so aptly addressed the Titanic issue, which is such a great learning for us, and it was a board decision to go with the minimum number of lifeboats and not go with the adequate number of lifeboats. And 1,500 people died, 700 people made it. But it was a board decision. It was a resource allocation decision. It was, that was how that disaster occurred. And it was, I'm sure they didn't really dig into the safety of the Titanic, and it was unsinkable, and they had the best technology of their time, which is what we say about healthcare. And yet some of these very fundamental decisions are there. Sharon, your message, we've talked with every panelist and kind of prepared, what's the kernel of the most important message for this issue of leadership?
You know, I think the message actually builds upon what the previous panelists have said. You know, one, embrace people from outside the industry, bring them in, but within that, be very deliberate and intentional in onboarding, and that was one of the things that I was initially afraid of, is that I didn't have a clinical background. So be intentional about the onboarding process and the engaging. Accept them, want them to be engaged, and help them be engaged. And probably the final message would really be around insist on boardroom training. Those trustees want to learn. And so that partnership between the clinical and the non-clinical, so exactly your point, is exactly what helped me really learn a new passion in this field, is that my partner was the chief medical officer. Well, what we found out is that there was equal learning. My business background with his clinical background really helped us emerge in the boardroom and have conversations that probably would not have existed previously if they had not engaged the business people that they brought on the board. So I really think it's important to embrace business people, embrace people from outside the field, and bring them in and make them feel welcome.
What's your message to other potential trustees or trustees about the invisible safety net? How do you communicate, as you did so eloquently, that they own it, they need to know what it is, and it might take a little more than a couple of minutes to learn?
To the point earlier, become engaged. I make rounds with the CEO, the COO, and the chief medical officer. And these aren't staged rounds. This is just a normal rounding process. So become engaged, understand the complexities of the hospital system, but then also take a step back and understand the patient's perspective. If you haven't been in that position, understand that someone has, and then understand what's going on around you.
Great. David, we frequently, it's so much fun to know all of you and to know all of the panelists and to have the history that we've had and the shake our head moments and the humorous moments. And David tells a wonderful story about sterilization, which is so apt, and sterilization of instruments. Just want to, I saw somebody look at me over here and went, what? So for those that are on the global streaming or on the WebEx, we're not talking about anything other than sterilizing surgical instruments, as I reiterate. I don't want to get somebody, a public servant, in trouble here. You know, we haven't even started our morning yet. But David, tell the story of the Tale of Two Surgeons and how it applies to what we are doing today in safety and quality.
Oh, I love to tell this story because it's actually the story of the intersection of the lives of two of the most prominent surgeons that we've ever had, Joseph Lister and Theodore Roth. And so many of you who have, are in surgery or know about surgery will understand that the history of surgery to a large extent can be divided into the time before Lister and after Lister. The improvements that he made actually allowed us to develop modern surgical technique, that is, to use aseptic technique. The interesting thing about his story, though, is that even in his own hospital, Lister was not able to actually convince his fellow surgeons about the benefits of his work. It took a surgeon hundreds of miles away in the person of Theodore Roth, who was actually able to implement a system that actually propelled surgery into the modern age. Now, Theodore Roth was the chief executive officer at Allgemein's, a clinic in Vienna, and the reason he was able to do what he was able to do, he understood the work of Lister and he saw his potential. But he was also the CEO, effectively, and the board, actually. At that time, it was in the form of one person. So he had the leadership. He knew what was needed to be done, and he had that quintessential manifestation of leadership. He had a good team. He had a team that was willing to work within a system. And because of his advancement and his support of the system of aseptic technique of Joseph Lister, it actually took hold within the world of surgery, and the rest, as you say, is sort of history. Later, Lister was acknowledged for his work, but it was very interesting how in the very first days, it was the leadership of Theodore Roth that made the day.
The old biblical phrase, a prophet is without honor in his own country.
Absolutely.
Exactly. Took
Absolutely.
my next line, so now I don't know what to say. So David, apply that to the challenges that you face in your division, and your part of our government is really focused on health information technology adoption. Is that a fair statement? And then how does that apply?
Oh, exactly. First of all, it's wonderful to see the story come back around full circle into the discussion of leadership. So many times in medicine we get attracted to and we gravitate to that new technology, that new gee-whiz thing. And first it was a new drug or a new gene therapy. And people will start to talk about this new technology, information technology. Oh, that will be the savior. But that's just a path, and that's not the whole answer. It really is all about leadership. A lot of times people will say, oh, your office is into technology. And I say, no, we're actually agents of change. The technology is a bit of, is the path. It's the way that we'll do things. But really, our job is to improve the quality, the safety, and the efficiency of healthcare services that are delivered in the United States. It just happens that we're doing that through the propagation and through the empowerment of providers using information technology. But this is not a technology enterprise. This is really about leadership and the development of a culture that can trust leaders.
What a great introduction to Bob Chapman. So I took a course at Harvard, an intense course with CEOs from all over the world, and it was an experiment by Bill George, who was at the end of the movie, who wrote True North, Authentic Leadership. He took Medtronic, a company at $1.6 billion, and said at this first day of employment, in 10 years I will be resigning and retiring, regardless of what happens. He did. He took it from 1.6 billion to 16 billion. He went into operating rooms for 2,000 operations, partnering with the clinical partners center so that he could learn. He had no knowledge of the clinical area. And I took this course, and the course was about your own journey as a leader. It was all about leadership and what your crucibles were. And one of the exercises was write down the 3 most inspirational people in your life. And I went, wow, that is a great question. And I've only known Bob for a couple of years, and Bob Chapman's on my list. Because Bob really, as you saw in the movie, in our last decade at TMIT, our first, and those that are on the webinar, you'll see it, you can see it tomorrow on the Discovery Channel, is that in our first decade, we were a technology accelerator, thinking, as David said, the whiz-bang stuff was the technology. Then we thought it was best practices, and David and I and Steve Swenson and a number of us have all been working on best practices enabled by technology. But you know, in the end, it begins with leadership, it ends with leadership, it's all about leadership. And Bob has really given us new inspiration about what leadership really is. Bob?
I think as I heard the congressman talk earlier and as I watched the movie, what occurs to me is the crisis in America is not a financial crisis. The crisis in America is the lack of leadership. And leadership is the stewardship of the lives under which we have the opportunity to influence. So when I think of healthcare and I think of the caregivers, those people who dedicate their lives to the care of others, who enter for a noble purpose, a very demanding profession where people's lives are at stake, that the leadership model in healthcare is broken. We talk about it being about the patient. It is about the caregivers as much as the patient. We talk about the convergence of leadership, safe practices, and technology. Unfortunately, technology and safe practices are progressing dramatically, okay? But what does not exist is the leadership where we care for the caregivers. In the work we have done, it is very clear that people just want to know that they matter. And until we engage people's heads and hearts in caregiving, we will never provide safe and compassionate care to the extent our technology and safe practices exist. We are not creating leaders who understand the profound significance of their leadership. It is not all about the patient. It is about all the people who are in the process of delivering health care, and therefore, if they feel cared for, they will engage their head and heart and yield the safe practices, bring the technology, but it is not all about the patient. What about, the congressman talked about his triplets, and he had great emotion when he talked about his triplets. Some of those triplets someday may enter a healthcare organization, not as a patient, but as a caregiver. Are they going to be treated the way he would like his triplets treated? That is the issue we face in all facets of America. We face it in our government, we face it in healthcare, we face it in industry. In industry, you talk about the customer's number one. The customer's not number one. People are number one. And we just are not creating leaders. And therefore, our healthcare system is suffering the same challenges. It creates all this great technology and great safe practices, but it's not saving lives as it would thoughtfully do. What about the caregivers? What in our boardrooms, what in the trustees of the hospital, how are we caring for the caregivers so they can render safe and compassionate care?
Mary Foley has been a wonderful, do you have a mic? You do, great. Mary Foley was the former president of the American Nursing Association. She is one of what we call our leadership, our listening leadership team. Every other Saturday, a group of family members who've lost a loved one through healthcare harm are working together, mostly consumers, and there are 2 or 3 of us that are clinicians, and every morning, just like we had my son, little Charlie, come up here, he'll crawl into my lap and be part of our meetings. And she's one of a wonderful group of real champions, along with Jenny Dingman, who's also a consumer that was in the film, dedicated to patient safety and quality. Now, what's different about Mary as a nurse is that she had an event happen in her own life. And she also sees what's going on in healthcare and how we are putting the blame on nurses. And pharmacists and frontline caregivers, when we have a systems accident, the easiest thing to do is to point our finger at the nurse, which is the most common one that we have. So two issues, Mary. One is that what's your message to the leaders of our hospital systems? Because you see both sides. You're trained, and she has a PhD and is focused and dedicated her life to patient safety and quality. These two issues of we saw the distrust of the ARC study. 600,000 staffers, 2/3 of them believe that they can't trust their leaders, Bob. They can't trust their leaders. 37% are afraid to report when an error is evolving, and a majority of them believe that when an error happens, that it goes into their job file, goes into their employment record. Address those two issues for us.
Chuck, thanks for the opportunity to speak from both of my roles. I gave a leadership talk last week, and one of the messages I gave to nursing faculty leaders is to be a good leader, you have to be a good follower. And I think the message that I heard in the film and I've heard here is the frontline staff really know, as well as the patient and family, really know what's going on. And if we actively listen as leaders to their information, their critical warning signs about how things are not feeling safe, then you will be a better leader. So making rounds, I think, is great with the CEO, but people know who the CEO is. I would suggest some stealth trustee rounds and partner up perhaps with one of the charge nurses or maybe one of the frontline pharmacists and just get out there and hear what staff really feel. They don't say Yahoo at the beginning of the day. They grip their hands and say, let's get through today and see if we can keep it safe.
The Lucy clip.
It is, yeah. So listening, learning really what the frontline staff are saying, they would then better trust you with the information about errors and harm because they are afraid. They believe in the systems, but they're not empowered to use the systems. So I've been thinking very deeply about what is patient-centered care. I think patient-centered care is a goal, but I don't think we have the tools or the processes that are very, very clear, that are tangible, a word that I'm using more these days, to help people practice patient-centeredness, to put in the hands of nurses, patients, and families the checklists that will keep them safe, whether they're giving meds or administering a dressing change or instructing patients and families in the next transition in care. We're not working from system guidelines, so there's a lot of variation in practice. But with leadership, those would be in place. With leadership, they would be enforced, and then staff would say, phew, I feel a lot better today that the structure is supporting my safer care.
You know, I don't think that there's a better example of a servant leader than Steve Swenson. And Steve has now been given the charge at the Mayo Clinic to carry its culture forward. And anyone that's been to the Mayo Clinic can get a taste of that culture, and it's an honor to for me to have an appointment there in Health Services Engineering. You're going to help take the Mayo Clinic to the whole next generation and take the physicians and the administrators and the entire care force of over 55,000 employees to the next generation of leadership. Steve, you've been benchmarking the greatest leadership out there in order to do that and you're a great leader yourself. What's your advice and what have you learned? And we'll close with that and then move to our next panel.
All staff in an organization look at leaders, for example. So the opportunity to role model is stupendous. It's powerful. And to do work in healthcare, you have two jobs: to do your work and to improve your work. So you have to have some basic understanding of systems competency. At Mayo now we have 25,227 staff that are trained up as quality fellows, which is a basic level of systems competency, green belt, black belt, master black belt. And that happened not because we required them to do it. It happened because the first people to get trained up as Mayo Clinic quality fellows were our CEO, Dr. John Noseworthy, and our CEO, Ms. Shirley Weiss. And just by having that example out there, and the staff said, this looks like it's something to do, and just spontaneously happened. So the role modeling lever of a respected leader in an organization is very powerful, and we need to use it.
And I've just been informed we're ahead of schedule. We've also got some folks that are delayed on flights coming in, so you get to give us more insights. And one of the areas, David, that we've talked about is, and we may even still let Steve give the last word again. David, we've talked about the fact that we're woefully unprepared to be trustees as physicians. We come into the boardroom with a mindset that as a physician, and we have our beefs. We know why it's not working, how it's not working, and we're kind of ready to clean up the action. And it's a big surprise, isn't it, to go into the boardroom and kind of find out how these big systems operate. As you look back and as you look to other folks that would then seek to be, and we hope would go onto the boards of trustees of hospitals, what's your advice?
My advice is that we have to work on both the knowledge base or cognitive gaps as well as the emotional gaps. And if you're going to care for patients and family members, any human being well, you have to have, you really have to combine the analytic skills with the social and emotional skills. And, you know, we train...
And doctors are really known for that.
Yeah, right. You know, I went to school and trained till I was 34, and it really was a focus on optimizing critical and analytical skills. And the humbling reality is that you can't be a good doctor, you can't be a good leader if you're not really connecting with not only your patients, but every human being that you're interacting with in an emotional kind of way. You know, I have and so really board members have to go beyond just a cognitive, intellectual exercise. It has to be a people-connected exercise. So for me and my family, since from the time I was 11 years old, when my 12-year-old sister, Debbie, was diagnosed with acute myelogenous leukemia and died within a year, it became clear to me that knowledge base was not enough. The disease itself impacted our family in a very negative way, but the type of care really impacted, in 1972 and 73, impacted us in a very negative way that indicated that really intellectual exercises aren't enough for patients. We were hurt by the disease less than we were really hurt by the lack of social and emotional connection. So that's a real guiding principle for me as I take care of patients. And to the other panelists' point, we're taking care of patients, healthcare professionals, everybody we come in contact with. And board members really want to serve, they want to have that connection. It's just a matter of finding a pathway forward.
John, build on that, because you spend a lot of time in boardrooms, and maybe we need a little dose of reality, because the group in this room are high performers with terrific track histories that are out on the leading edge of leadership. John, you're parachuted into a typical St. Elsewhere board. What are you seeing in America today? What's the reality, so we could really...
Or as I put it, Our Lady of Pretty Good Outcomes Memorial. But yeah, the average board is filled with wonderfully dedicated folks who are trying to give back to their community. Many of them are business people. They are much more adept at dealing with dollars and cents than they are dealing with the clinical realities. One of our problems, I mean, there are a number of them here. One of them is that the Darling case back in 1965, in which basically the nation turned and said, you know, who's the final responsible party for any clinical decision? It's the board of directors. That went right past everyone. They turned around and put it on the CMO. The chief medical officer, or his or her equivalent, I always call an ambassador without a country, because they're not a member really of the C-suite, and yet they crossed over to the dark side in the attitude of all the docs, and they are in this netherworld, and the board has repeatedly, in so many thousands of instances, thrown things at them and said, well, that's a clinical decision. You just take care of it. Disruptive behavior by physicians, which is a small percentage, but extremely important, terribly deleterious to patient safety. It has been passed off to people who just do not have the horsepower to do anything about it. So when you look at the average board today, one of the things you have to say is, first of all, we need accelerated education. We probably are going to have to start paying you at some point, because we're going to need to extract a tremendous amount of your time. Thirdly, if you cannot get engaged with the clinical and understand this, then it is time for us to thank you for your service and let's get somebody else on this board. This is why it's important to have physicians on the board, not dominating it, but physicians who understand, as David is indicating, the interface and the difficulty of trying to come out of the clinical and look at the big picture, but still stay engaged with the clinical. But this is going to be one of our keys, especially when we're trying to get things established here that we know from, whether aviation or otherwise, are necessary for patient safety. And one of them, and you know, you led, I think everybody has into this, especially in terms of care for the caregiver. This is a human institution. Clinical distance can go too far. It has. We have to focus not on the caregiver and the patient. And when I say patient-centric, one of the things I'm trying to differentiate from is physician-centric, because that's the way we always did it. It was a farmer's market, hospital, run for the doctors. Now we have to change this around. Everyone in the hospital, all the way down to the lowest supposed level in the front lines, has to own it. They have to be not engaged, but owners of it. And that's Southwest Airlines, if you want to look at my other profession.
Absolutely. Sharon, you are a trustee at a safety net hospital, and we have a number of them. Most people don't know what a safety net hospital is. Most people don't know that in about 300 communities across America, the most vulnerable populations are being treated out of almost 6,000 hospitals. And they have very unique challenges today that I don't think our nation is rallying behind because A, we don't really know the need, and B, we don't know how bad it's getting and how bad it's going to get even further when we have cuts. Because when we have cuts, you're already on strands, right? So tell us what a safety net hospital is and what the unique leadership and government's issues are.
Well, safety net hospitals care for our most vulnerable populations, as you've indicated, and those are the people who have no insurance or underinsured. For example, our Sinai Health System, 60% of our population is Medicare, Medicaid rather. 20% is Medicare. So as the cuts are starting to take place, we're really looking at populations that we're not sure how they're going to continue to receive care if our doors close. And in our case, we're one of the few remaining safety nets in the Chicagoland area. But to your question about what are some of the challenges is the talent. The good news for us is that the caregivers that are there are people that genuinely care and are passionate and easily could go elsewhere and make much more money. But they understand the need and they genuinely care about the population that is served there. And so at some point, though, you can only thin your staff so far, and to the point where then they're overtaxed. And then the caregivers do begin making honest mistakes, not that they're not making honest mistakes otherwise, but then they're overtired, and then the hours are longer. And so the issues begin to just compound themselves. And the same thing with the leadership team. You still need the leaders there to help guide the administration, to help guide the effort of the system. So at the end of the day, the cuts that are on the table for Medicaid and Medicare are instrumental to keeping the doors open for these vulnerable populations. Otherwise, where are they going to go for care?
And the cost of harm can pull you under. Whereas a typical hospital might have enough margin to get away with being inefficient, unreliable, and allow readmissions to occur. That may not be the case.
Right. These cuts will be the difference between doors opening, staying open, and closing.
Doors closing.
Yes.
So, David, you're sitting next to Bob Chapman, and in our session before we went live, he articulated a challenge of a vision statement for us for hospitals and healthcare. Loved ones caring for loved ones. Is that too touchy-feely for doctors? You're out there constantly talking about IT, technical things, clinical things, measurement, and I know you well enough to know that you don't think so. Tell me why.
Well, I would say probably because it brings us back to, again, why we started into this whole business of medicine, of caring for people. And it gives physicians and caregivers, clinicians, another tool, another resource, because no one wants to ever harm anyone. No one, the devastation that it entails on the patient is in some ways also reflected on the caregiver. And having the family involved, having other caregivers involved, actually helps build a larger safety net. It gives physicians another resource that they can rely on. But we've got to be taught to be able to trust these other resources, to be able to listen to the family members that come and sit next to the patient in the hospital. We've got to be trained to understand that we can listen from a number of different channels to get all of the information that's needed. But I also wanted to touch on one thing that you mentioned. We talked a little bit about safety net hospitals, and we talked a little bit about the costs of care. One thing that isn't frequently discussed is the fact that safety net hospitals are taking care of, again, our most vulnerable patients, and we pay such a tremendous cost not only in care that is delivered poorly, but in disparate care. That is to say, healthcare disparities may account for up to one-third of the increase in costs that we see every year in healthcare.
Across the nation.
Exactly. So when we talk about being able to deliver care that's better and safer, in part, we're also talking about the elimination of disparities in care, disparities for the minorities, for the underserved as far as care. And that is a safety issue in and of itself also.
If I may, because this is a really important point. We have a nation full of people who do not understand what's going on. They don't understand the equation. There's been a debate in the last number of years about whether there should be universal health care. We made that decision decades ago when we said that if you wobble into an emergency room, you're going to be seen. But we're doing this in the most inefficient and ridiculous way we possibly can. We as a people have got to figure this out in a way, and I know there's a debate about which way you go, but it is not a situation of should we or shouldn't we. We're already there.
We're already there.
Yes.
And we're very inefficient. So Bob, we've heard your vision of loved ones caring for loved ones. Tell us about your what's the snapshot of your leadership model? What is the essence of your leadership model for those that want to know more of what it is?
Well, the expression we came to is we measure success by the way we touch the lives of people, which applies to healthcare, it applies to manufacturing, it applies to every facet of leadership. And if you stop and think about those precious people that dedicate their lives, those nurses, when I give a talk on leadership, one of the things people say is, I got 10 things right, and I never heard a word. And I made one mistake, and I never heard the end of it. And it destroys lives of nurses, of doctors. And in our leadership model, it's no different than you raising Charlie. Our leadership model is identical to parenting, okay? Our leadership model focuses on holding up the goodness, okay? Constantly focusing on it. If the trustees in the boardroom are always talking about metrics and errors, what about all the good things people have done in the hospital? Do you have a balance? If you raise children and more than 50% of your comments are what they're doing wrong, you are raising a child who lives in an oppressive environment. If we're raising our institutions where we're focusing on what we got wrong, the issues we face, and we don't give proper recognition to the good things these nurses and doctors are doing, we are missing the opportunity to engage their heart and let them go home with a sense of fulfillment. We can talk about that precious child's life who's lost, who we can visualize the parents that we did today. But what about that precious life of that nurse that goes home feeling unappreciated for the gifts that she shared that day, okay? Because all the focus is on what somebody got wrong or cost or procedure. What we need in this country is to focus on all the people we touch in healthcare. And this came from a service organization, the Ritz Hotel. My wife and I were having breakfast one day, and we get an exceptional service. And I said to the lady giving me service for breakfast, "Why are you treating me so well?" And she pulled out a card, and it said, "Ladies and gentlemen serving ladies and gentlemen." What does that mean? That she felt as valued as us, and therefore she treated us the way she was treated. Only in healthcare, when we embrace that concept, will we ever deliver safe and compassionate and efficient care. All of the emphasis are on procedures, and it needs to be on those precious caregivers who, if we gave them the opportunity and we gave them the recognition, holding up the goodness in them, not focusing on the brokenness, will we create the kind of health care that we want to be a part of that touches our families.
For those that have logged on globally or are on our webinar who have not seen our documentary, Surfing the Healthcare Tsunami. Bob Chapman is the chairman CEO of Barry Waymiller Companies. By any metric, for those of us that have background in business and other areas, by any metric, over 50 acquisitions, almost 60 acquisitions, almost all successful, over $1.3 billion in revenue, incredible financial growth. And yet we're hearing about the heart and about the care and personal empowerment. And I think this is what we want to hear. We just have a hard time believing that the byproduct of having that kind of focus could actually translate into the typical business metrics. But we also heard Clay Christensen, the much beloved professor at Harvard Business School, when I asked him, and those that are logging on will get to see it tomorrow if they watch the Discovery movie, and I asked more of Clay, which is not in the movie, and I said, do you think it's possible that there could be a Collins level 6 leader? Jim Collins was also in the film, wrote the book Good to Great, and I asked Clay Christensen, you think there's a level 6 leader? And he said, what do you mean? And I said, do you think that there's a leader that can create an environment where joy can be the focus, that can have a byproduct of the kind of performance at Harvard Business School that they would believe is great? And he said, absolutely, but he hadn't met Bob yet.
So Chuck, I can see why Bob's on your list of influential people. And that's a message that I hope permeates healthcare, a really important message. I've been in my quest of doing my studies, looking at healthcare worker injury, risk of harm from needle sticks, back injury, violence, chemical exposures, and I see an incredible alignment. I'd say to the trustees here and those of you in training, why aren't those metrics looked at side by side with the patient safety metrics? And I think if you would align the two sets of strategies, you'd see incredible similarity. Safety climate, safety culture, we even call it different things. I think it's one thing. It is the right climate in which the caregiver is cared for and then empowered and feels safe to give the best care they possibly can, because their focus can then shift to what they want to do, which is to be the best professional they can be. So I think it's a wonderful conversation. I'm glad you've raised it. I think these kinds of decision leaders and folks who are leading the way will make a difference in leadership, and I'm glad to be part of that journey.
Great, Mary. Next question. I'll give you a second question,
Okay.
and that is care of the caregiver.
Yeah.
Because it builds on what Bob is telling us that we need to do. If we exhibit, as you told me, Bob, in casual conversations, the same kind of unconditional love, and think of an employee the way we would think of our own child, and even when they're not behaving the way we would want them to behave, but have that unconditional love that we have for a child rather than discard them. We're discarding a lot of nurses, a lot of pharmacists. We put that in our film for those that haven't watched it yet. We addressed a pharmacist that was criminally, was indicted for actually signing a piece of paper and signing off on a clear IV bag of fluid that he couldn't possibly measure to determine whether it was properly prepared or not. And because of the state that he was in, it's a felony if you sign a piece of paper with your signature that leads to a death, it's a felony. And I know Chris Jerry is here, and it was so joyful to see forgiveness, true forgiveness. And we were excited to be able to tell the story of that forgiveness, but that forgiveness is not happening in America today. We have nurses that are committing suicide, leaving the practice, and it is very easy and convenient when you have a system failure to point at a bad apple, because they're defenseless and they're vulnerable. And in the case of some of them that we've seen, the records of the interview after an event are released so that the indictment really happens. And we see that as an active thing. I'm ashamed to say that's in our industry. Address this issue of where are nurses' heads today? At the front line, where are they today? The ARC study said 2/3 believe that they can't trust their leaders.
Yeah, and I think that's really sad because they really do want to be part of a team. Healthcare is team sport. It is not an individual activity. It isn't just doctors, just nurses, or the CFO, who we think sometimes they think they do run it. It is really a team, and a just culture is what we're really talking about here. An environment in which the leaders follow, the followers feel very instructive in the care that's being given, and the leader will stand there and say, how can I remove the barriers for you so that you can do the best you can? What's the barrier today to giving you for you giving that medication as safely as possible? What is the barrier? And then systematically take a look at the structures, the support, the resources, the equipment, the computer, whatever it takes to then guide that setting so that it's safer. When a staff person is asked to file a report, A, they're either suspicious that it is going in their file. More importantly, they don't think it makes a bit of difference. They don't feel that there's anything different tomorrow than happened the day before as a result of reporting a near miss or perhaps an actual error. And that's really sad because there has been a pattern of nothing changing. And you show up again on Tuesday and it's just like it was on Monday and you wonder, when are they going to get the message? How many people have to be hurt? How bad do the headlines have to be before there's actually a response? So it is leadership, Chuck. I mean, it definitely is leadership, helping the folks giving the care to do the best they can.
Well, I'd like to thank this panel, terrific panel. We're going to keep moving forward with our groups, but thank you very much. And I know that our audience here at the National Press Club are the other panelists and staff, and I know there'll be an opportunity to cross-pollinate as we move to shuffle the deck of our panels. But all of you are great leaders and great role models, and we're so grateful to have this much talent up on the stage. We could make a whole day of it. Thank you very much.